بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. In case of the week 9 at our channel for the passion, this is a case referred to my center for third trimester anomaly scan at 34 weeks gestational age. Here is the scene loops of the case. The first scene loop shows a VSD. You will notice right here a VSD. The VSD shows bidirectional flow on color Doppler. And here is the aorta that is seen overriding the ventricular septal defect, with the interventricular septum seen pointing to the center of the aorta. Again, the aortic overriding. And here is the overriding again with color Doppler, and you will notice that there is the aorta has color flow from both ventricles. There is ejection of blood into the aorta from both ventricles. Here is an image of the three-vessel view. You will notice that the pulmonary artery is the most left lateral vessel is smaller than the aorta. It is supposed to be slightly, more or less slightly larger than the aorta. And this is abnormal. But both the aorta and pulmonary artery has forward flow. Again, summation of findings. There is a VSD. Subaortic. The VSD has bidirectional color flow on color Doppler, and the thymus is of normal size. Normally it should be more than 35%. You will consider a chromosomal anomaly if it is slightly less than 30%, and 22q11 if it is smaller than 20% of the thoracic ratio. This is the thymothoracic ratio, measured from the sternum to the anterior border of the aorta, and from the sternum to the anterior body of vertebra. And here is the normal three-vessel view. You will notice that the pulmonary artery is larger than the aorta, slightly larger. But in our case, actually the pulmonary artery is smaller than the aorta. Again, pulmonary artery is smaller than the aorta, smaller than aorta. And again, the velocity at the pulmonary artery was within normal range. And here is another finding, the only other finding that was found in this case. That's 11 pairs of ribs. Here is an explanation with images of the subaortic VSD. Here is the subaortic VSD that is not malaligned with no appreciable overriding. You will notice that the interventricular septum points to the anterior wall of the aorta. The aorta is not overriding. But here you will notice a subaortic VSD while the aorta is overriding, and there is malalignment because the interventricular septum is pointing towards the center of the aorta. And the aorta receives flow from both ventricles. So the findings are subaortic malaligned VSD, aorta overrides the VSD, narrowed pulmonary artery, 11 pairs of ribs. So the diagnosis is Tetralogy of Fallot with 11 pairs of ribs. The tetralogy comprises subaortic VSD caused by malalignment between the infundibular and trabecular septum, an aorta overriding the VSD, obstruction of varying severity of the right outflow tract, consequent hypertrophy of the right ventricle mostly after birth. The incidence is relatively high, 1 per 3,600 live births, and about 7% of infants with congenital heart disease. Tetralogy of Fallot comprises a spectrum with the most common three subtypes are tetralogy of Fallot with pulmonary stenosis, like in our case, which is found in 80% of tetralogy of Fallot cases, tetralogy of Fallot with pulmonary atresia, and tetralogy of Fallot with absent pulmonary valve syndrome. Here is an example of tetralogy of Fallot with pulmonary atresia. You will notice that the flow in the pulmonary, a smaller pulmonary artery, is ductus dependent. The flow comes from the aorta, so due to atretic pulmonary artery. And here is another example of tetralogy of Fallot with absent pulmonary valve syndrome, with the hallmark of this diagnosis being the aneurysmal dilatation of right and left branches of pulmonary artery. Associated cardiac malformations include right aortic arch, atrioventricular septal defect, which increases the risk of chromosomal anomalies subsequently, atrial septal defect or a patent foramen ovale, persistent left superior vena cava, variations in coronary artery anatomy that may have an impact on the surgical approach to repair. Associated extracardiac malformations include chromosomal anomalies that are seen in about 30% of fetal cases, trisomy 21, 18, and 13, 22q11 microdeletion, especially with right-sided aortic arch and thymic hypoplasia. Karyotyping or Bitra microarray should be offered in case of tetralogy of Fallot. Many non-chromosomal syndromes such as Alagille, Charge, and Frenz syndromes. Obstetric management, karyotyping microarray, detailed anomaly scan with fetal echocardiography, sonographic follow-up of diameter, flow velocities, and direction of flow at pulmonary artery, delivery in a tertiary center. The prognosis, poor prognostic signs that will predict the need for early neonatal intervention include pulmonary valve peak systolic velocity more than 87.5 cm per second at 19 to 22 weeks, or more than 144.5 cm per second at any time, bidirectional or reversal flow at pulmonary artery, pulmonary valve to aortic valve ratio of less than 0.6, pulmonary valve z-score of -3. Other poor prognostic factors include decelerated growth of pulmonary artery, accelerated growth of ascending aorta, tetralogy of Fallot with pulmonary atresia and with absent pulmonary valve, small left ventricle, associated chromosomal anomalies. The take-home message: malaligned subaortic VSD with aortic overriding and smaller pulmonary artery than aorta are the hallmark of tetralogy of Fallot. High risk for chromosomal anomalies necessitate a microarray. Not only we can diagnose the tetralogy of Fallot at fetal life, but we can prognosticate cases and highlight the need for neonatal intervention. Kind regards and see you soon. Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Amr Farouk.